A 62-year-old male presents to the emergency department complaining of mild dizziness. Laboratory result: potassium 6.8 millimole per liter, sodium 138 millimole per liter, creatinine 0.9 milligram per deciliter, ECG normal. The laboratory report: hemolysis index elevated. A repeated specimen collected carefully shows this potassium 4.5 millimole per liter. What is the immediate concern? Potassium concentration of 6.8 millimole per liter is potentially dangerous. True hyperkalemia may cause cardiac arrhythmia, ventricular fibrillation, cardiac arrest. Therefore, the physician must determine whether this result is real. What findings don't fit? Several findings are suspicious. Normal ECG, true potassium level approaching 7 millimole per liter often produce peak TV waves, PR prolongation, widened QRS complex. The ECG is normal renal function. Creatinine is normal. Most severe hyperkalemia occur in patients with renal failure, severe metabolic acidosis, massive tissue breakdown. None are present. Laboratory clue: the analyzer reports hemolysis index elevated. This is the critical clue. Pathophysiology: red blood cell contain approximately 20 to 30 times more potassium than plasma. When erythrocyte rupture, potassium leak into serum. The analyzer measure this leaked potassium. Result: pseudo hyperkalemia. The patient potassium is normal, the specimen potassium is abnormal. What other tests might be affected? Hemolysis commonly cause potassium high, LDH high, AST high, folate, glucose reduced, sodium reduced, chloride reduced. Final diagnosis: severe specimen hemolysis causing pseudo-hyperkalemia. Never treat laboratory hyperkalemia before correlating with clinical finding, ECG finding, hemolysis index. A patient should not receive insulin, glucose, or dialysis for a laboratory artifact. Patient 540 years old male undergoes annual laboratory testing. Blood is collected at a satellite clinic. The sample remain uncentrifuged, refrigerated overnight. The next morning, laboratory results show potassium 3.3 millimole per liter, sodium normal, creatinine normal, hemolysis index normal. Initial interpretation: the physician suspects hyperkalemia, however, patient feels well. Kidney function is normal. No medication explain hyperkalemia. Why was hemolysis index normal? Because no hemolysis occurred, the red blood cell remain intact. Therefore, the analyzer doesn't flag the specimen. This makes the error particularly dangerous. What happened during refrigeration? Red blood cells contain a membrane pump, sodium potassium ATPase. Normal 3 sodium ions move out, 2 sodium ions move in. These require ATP. Effect of cold temperature: at 4 centigrade, cellular metabolism shows ATP production decreases. The sodium potassium pump become ineffective. Potassium begin accumulating outside the cell. Result: artificially elevated serum potassium without hemolysis. Why this is critically important? A laboratory reports the value because hemolysis index is normal, sample appear acceptable. The physician may incorrectly diagnose renal disease, renal insufficiency, hyperkalemia. Final diagnosis: refrigerating induced pseudo-hyperkalemia. Prevention: best practice: centrifuge sample promptly, separate serum from cell quickly, avoid refrigeration or refrigerating whole blood before centrifuge. Comparison of the two cases. Case number 1, hemolysis. Case number 2, refrigeration. Potassium in case number 1 increased. In case number 2 increased also. Hemolysis index elevated in case number 1. Normal in case number 2. RBC's rupture. Case number 1, yes. In case number 2, no. Analyzer warning. Case number 1, yes. In case number 2, no. Analyzer warning. Risk of misinterpretation. Case number 1, moderate. Case number 1, moderate. Case number 2, high. Both patient appears to have dangerous hyperkalemia. Neither patient actually had hyperkalemia. The difference between laboratory artifact and the true disease diagnosis depend on understanding hemolysis, sample handling, pre-analytical variation, clinical correlation. This is one of the most important lesson in clinical chemistry. Treat the patient, not just the laboratory result.